Hi there, welcome to the More Sibyl podcast. This is a podcast for Blacks, Asians, and those who love them. I am Mo, and I am your host, ready to spark your curiosity as I take you on this adventurous ride of exploring cultures through the stories of my guests from all over the world. On this show, we get really personal, discussing salient issues that are relevant to our contemporary age and also building community around them. As our guests exercise courage and vulnerability in sharing their life's experiences, we hope that in turn you are inspired by them and that you get the courage needed to set your own stories free. Enjoy the ride, and thank you so much for listening. To the show. This is Mo, and today I have a very special edition with two wonderful people. First we have
T-Dog.
T-Dog. He's no stranger to the show, but this is Dr. Ibukun Money Pumping Sonaike. He's a pediatrician.
Amen.
Pediatric intensivist in making.
Yes. This guy is, what do you say, Igiwe? Like the fountain, the tree of knowledge. Yeah, we've been friends. Well, I've been friends with him. I think I knew him more in med school. Did you guys talk in med school?
On the school level.
School level. So shout out to our CFG peeps, Christian Fellowship Group. Anyways, Ibukun and Taiwo ended up meeting here again at the other school, Texas A&M. Yeah. And so the rest of this is history. And we've kind of kept in touch. Ibukun is somebody that, when we talk, I just laugh. Like, he makes me laugh like crazy. He has a serious look on his face, but do not be fooled by this.
It's packaging.
Do not be fooled by this content as well. I guess let me let you introduce yourself, and then he can introduce himself.
Well, I don't think I need any introduction anymore. You guys know me by now. Taiwo Ledike. Fortunate and lucky to be married to this beautiful damsel. Anyways, yeah.
And thanks for coming on the show. It means a lot. They always begging me.
But you have to pay me though. Anyway, go ahead.
Yeah, I'm here because I was told there will be some financial. So my name is Ibukun Sonaike. Most of my friends call me IBK. I think that's and I've been friends with Taiwo and Tolani for a few years now back in med school.
Yeah.
And we've just, like Tolani said, kind of kept in touch. And just nice to be spending some time with them during this brief period. Yeah,
Ibukun's a very good friend, and he's visiting here from Seattle, and I thought, why not just kill two birds with one stone? We were to introduce ourselves, and so the commonality between the two is that they're physicians here. Taiwo currently works as a hospitalist. He did his residency in family medicine. And Ibukun, they also have master's degree in public health. Even though I know this one has not been used. It hasn't used his degree one time.
So I'm doing an MBA.
I'm telling you.
Yeah, I think an MBA would have served me better, but anyway.
So I know why you went into medicine. Your personal story, at least the one that you put on your application, was your mom was ill and you nursed her back to health. What drove your decision to study medicine? Was it that whole thing of Nigeria, mom, like your dad, you have to go study?
I think for me, one of my uncles on my dad's side, like kind of when I was very, very little, I kind of admired him, and he was a doctor. So I think that's probably one of the first memories I had of wanting to become a doctor. And coming from Nigeria, there are probably major courses. Your family will always encourage you to study engineering, medicine, law, the major big courses that they should, serve you some security down the road. And I was and during secondary school, I kind of was really, really, really good in biology. So, I think it just, all that together, there was no one big factor. I've always liked to help people for sure, but I guess you could do that in other fields as well.
Sure.
So, nothing, I wouldn't say I had this one inspiring moment per se.
So another thing is that both of you have practiced in Nigeria, you also practice here. And knowing what I know about the system, there tends to be like a disconnection between reality and expectations, especially when you have to deal with like quality controls, admin, insurance. What would you say has just been a big difference between practicing in Nigeria and practicing here? Let's start with Tidal first.
I guess from my little stint, working in Nigeria, during my internship, which spanned a period of a year, and then I think I worked for about a year and a half in the private setting. I would say from my experiences, I think the main frustration was Scott work, which I didn't really have to deal with. I didn't really have to deal with, but probably Ibukun will be able to tell you some more. But I know that's very common in New York programs, where I think some of them kind of do Scott work, like do blood draws and stuff like that. That's not really related to medicine. But anyway, that was the norm in Nigeria when I did my house job, and also as a medical officer at the private hospital. And then other major things was where the fact that insurance wasn't like a big deal then. It was pretty much pay out of pocket. So even
means that model, right?
Yeah.
Even though it says a lot about our healthcare system, if the majority of population is paying out of pocket.
Yeah, it was pretty frustrating. Like I remember, and I'm sure Ibukun will also attest to this, like even during my med school days, during my clinical rotations, at the accident and emergency, we would have people coming in with, like major road traffic accidents, like lacerations, even medical issues, and the first thing they'll tell you to do, instead of trying to stabilize the patient first, it's like, okay, go get the cards, go pay this, go buy all this supplies and stuff like that, and most times people just lay down there and, eventually die, That was really, really frustrating for me, but I think one of the main differences here in the US is that, they take care of you first, address the emergency, and then you can get a pretty hefty bill later on, but they'll save your life.
Yeah, generations have to keep paying small for it.
Yeah.
There's going to be a prize at the end of this episode. Anyone that can tell us how many times TW uses the word, the Toastmaster means like, how many you have to put in the sentence, All right, Ibukun.
Okay, so I guess Taiwo has already touched on some of the glaring differences. Of course, the healthcare system, the way it's organized in itself, is probably a big, a source of frustration. And if not either of you, at least in my family, and I know in so many families, they've had stories where a family member or a loved one has had adverse outcomes, not because they did not present early enough, but before mobilization of the health services due to finance or even things not work. Sometimes you even have the money and there's no electricity or there's no blood. And I remember when my cousin was born and we thought we had to do exchange transfusion because our billing was quite high.
Bilirubin,
bilirubin, sorry. Yeah, our bilirubin was quite high. And that can affect the brain, especially in the early neonatal period. So, it causes kernicterus, which is so basically, we looked for blood. There was no blood at the hospital. We had to go outside to source at the private center. It was just...
And this was Lagos?
Yeah, this was in
Imagine
Lagos.
you were in the hinterland of Nigeria.
Hinterland, exactly. So, and I was a doctor working in that hospital. So you can imagine
They even got that special treatment already.
Yeah. No, I wouldn't say special treatment, but at least I knew where to go. I knew who to go.
That's special treatment.
Yeah.
How many people know
Who exactly know all these things? So imagine someone that is probably not that. Most
savvy.
people who are not. If you didn't study medicine, pharmacy, nursing,
you
really don't understand the system as much. So I can understand how confused, frustrated, how lost they would feel. With those kind of issues. So the Nigerian story is a complicated one.
Can't finish it today.
Yeah, in terms of Scott work, I think I would probably, and because myself and Taiwo, we have different parts or specialties. I think I'm actually appreciative that I was able to do, at least in terms of IVs, procedures, and all of that. Because being working in the ICU, just a lot of things. You have to place in central lines. You have to do bedside ultrasounds. You have to intubate patients. So, and sometimes, and yes, at the hospital where I currently work, it's not like for centralized you do them, but for an IV, someone else might come to do them, and if they don't get it, you still have to manage the patient. So it's good you have those skills. Yeah. So, but that's just different because we're in different fields in medicine. Yeah, but things work. I remember the first day I started residency, and we sent a lab. And within 15 minutes, my senior was asking me if the result was out. I was like, why would the result be out in 15 minutes?
But it can be possible.
No. It does come out, even sometimes even less so. Yeah, especially if you put a start on house. Even less so. But, then in Nigeria...
I think the problem we have in Nigeria really, and myself and a friend were trying to work on this, is our lack of centralized system. They don't communicate to each other. The patient has that onus of carrying their backpack of knowledge from one doctor to another doctor. And even here, sometimes systems might not communicate to each other, but at least within the hospital, you can have everything you need. You don't have to go to Yaba to go and do scan, go to Ojolegba to go and do ultrasound, So that's also the problem. And if you lose all of those, whatever, and who comes up with these results?
I feel like you could pick a problem and really go into depth. So I'll probably try not to talk about Nigeria too much. I'm not sure that's the scope of.
That's okay. I mean, we are Nigerians, and I know that for many of us, being here was not something that we wanted, to come consciously, but because we wanted to seek, greener pastures. But it's still our country, and the hope is that it gets better someday.
Yeah.
And I don't know if it was done talking. I was going to say also, that here in the States, right, you get frustrated, and I don't know if, Ibukun experiences that as well in terms of readmissions. There are lots of social and behavioral determinants of health that kind of affects our patient population.
Look at how you just in that public health, because I dissed him that I wasn't using his MPH degree. All of a sudden, he just slid that, social and, what did you call it again?
Behavioral determinants of health. Like, these are things that are real.
He took that course in first year.
Yeah. And these are real issues. You see patients coming in. I can tell you, based on their socioeconomic background, some of them are unemployed, or maybe they are underemployed. They can't afford insurance. I just took care of a patient, and I had to discharge the patient. But then guess what? The patient came back to the hospital in 5 days. Because no health insurance, no access to follow up. So you get frustrated too here.
Now, another question I'd like to ask both of you as the non-medical person here is, I've noticed this with a lot of my doctor people. I just not to say they're not nice people. I mean, for me to call you a friend, you have to be nice. So, but there's a point you guys get to that you almost start, you lose your, I don't know how to say it. You're used to seeing death and macabre and gruesome scenes, and then the way you talk about people dying, almost as if a fly just slammed themselves on the window, and then at what point does it not get scary? Is it that there's something about the way you guys practice that you start losing that sense of death? And I think we had that conversation, was it yesterday?
Yeah, we had a conversation.
2 kinds of patients that you talked about. Why do you think it gets to that point where it feels like you guys don't, I don't know how to call it. It's not being callous, but you guys just get very what's the word I'm looking for? Desensitized. God bless you.
Yeah.
And that's scary though sometimes, because I know you guys are very core of it. You do care. You actually care more about the disease than the people sometimes behind the disease.
Well, I'll tell you this. I don't believe that there might be a few doctors that have lost their sense of humanity, okay? They are in it just to make money, okay? And I would say that I think as physicians, we need to get to that point where we take ourselves, you try not to be emotionally involved in the doctor-patient relationship, and it's a difficult balance, really. You want to try and connect with the patients, gain trust, establish that relationship, so things can go well. But at the same time, you don't want to get too emotionally involved. I've seen doctors, during my training, I'm working at night with one of my female seniors, and she went in with a dying family, and, she cried with them, told them that, it's better to make the patient comfort measures. She cried with them. She showed her humanity.
Have you cried with the patient before?
I have not, but that doesn't mean, the fact that I've not cried does not mean that I don't feel, it doesn't mean that I do not feel for the family or stuff.
You cry later on in your closet, like when you're brushing your teeth off, like what up, like...
I just think about it, I reflect about it, I feel sad, but then the fact that I think I did my best for the patient makes me feel at ease, and I try not to think about that too much, otherwise I'm going to get depressed and,
So
you try to just remove yourself from that situation, because if you see death and all that going on every day,
it's just not normal.
Then lots of physicians commit suicide for a whole lot of other reasons. But I'm sure most of those people might actually like get those things into their head, like they're connecting too much. I don't know.
Yeah.
Like, you see that every day, and then if you have that tendency to become depressed, you can end up committing suicide yourself. So, it's hard.
So I know some days ago when you lost that patient that you didn't like, I know you needed a hug, so I gave you a hug. Because you were really sad. I could tell that on your face, like you were really sad.
My patient...
Better if you just cried. Maybe that felt a lot better.
No, I didn't need to have cried. Like, I had a patient that we established that relationship. He told me to hold his hands, I held his hands. His family was there, and they were like, he's telling you to hold his hand,
Yeah.
And that moment where you do that, you connect with that patient, you reassure them.
You hold your patients, and I know that they ask you to do that now as a pediatrician, right?
Not by default.
No, but there's a lot of hand holding. If you have to hold them to like maybe draw a line or...
That's different. That's different. No,
there's still,
a procedure.
I'm just trying to relate. Like, there's still hand holding. There's still a bit of contact. You probably have more contact with your patients as far as physical contact compared to child's patients.
He's dealing with parents and
children. That's what I'm saying. Yeah, you have like probably more contact. If you load your contact hours, and probably you have more of that. Would you say by virtue of the volume of contact you have, does that make you think you don't belong to this category of practitioners that are kind of like getting a little bit?
No, I think this thing is very, very, very multifaceted, and in a sense, it makes doctors look like a different breed. But if I were to compare it to something more mainstream, maybe we're not that different after all. For instance, now, with all the issues with police shootings and black people in the US currently, we don't necessarily talk about them, and we are sad in the moment. It's always contextualized. I think the thing with doctors is that a lot of times when we are discussing these patients, we are discussing them because of the medicine. We are usually discussing them because of the medicine. Like I think 2 nights ago, I think in that sense, when this discussion started, I think the main thrust was, okay, what actually happened to the patient? What was the pathophysiology? You get, so we're not really talking about, it's the medicine we are really talking about at that point in time. So, you have to talk about the medicine sometimes. Then there are also periods where it's the person. And in those periods, I think I'm usually more emotional. When I put myself in the family's shoes, I can't imagine what the child, to be at that age and to already be dealing with issues this deep. Or the parents, they are losing a son, they are losing a daughter. It's so difficult. Sometimes, it's end stage, it's terminal, there's no solution, they're just in pain. It's somewhat okay that, they're allowed to just let go and go rest. But at the same time, it's still heartbreaking that they had to go through it in the first instance. So it's very
it's not one, it's the
it just depends on, whenever you see a doctor discussing the patient, it depends on the reason he's discussing this patient. Is he discussing it because he wants to share, we had similar patients, but we did this differently, and this patient did better, or I didn't even really understand what was going on with that patient. It's a different discussion from, wow, this girl passed, the family was distraught, I felt very bad. Those are two separate discussions, yeah. And having said that, there's burnout. I think we have one of the highest rates of
Absolutely.
Because I didn't know with the patients, but also with the families.
The families, yeah. We have one of the highest rates of, I think, professional
Burnout
and suicide.
suicides. You know, a lot of people are with debts. A lot of people. We are probably not in that category, like medical school debts.
Oh, yeah.
There's a lot of financial pressure.
Yeah.
You know, if you're in medicine to make the money, I don't know if it's worth it. So, I don't know, and you also need a healthy distance. You know, I don't think you want me flying your plane if I was afraid of heights. Do you get it? If I was that, you know, like, you know, sometimes you're in the plane and there's this reverberation and you're just holding on for dear life, and you see one of these hostesses and they're just, what? Do you get? So you need a certain level of professional distance to objectively do the non-human aspects of the job.
I get that part. My own problem is that the distance becomes so much that you guys focus more on diseases and you don't allow yourself feel with the patients. Because I've had some doctors like that. It feels like they don't even see me as a patient. It's about your condition. They don't think about the person behind the condition.
I mean, if you had to have if you had to pick one, I think it's always good and important that a doctor cares and shows the human aspect of the profession. But I mean, if you had to pick one, a doctor that was too involved or a doctor that was distant, you want one that his mind was clear and he was just focusing on medicine than one that is so afraid he's going to make a mistake and he eventually either does make a mistake or doesn't do anything. So in a sense, you know, not every doctor is going to be able to show that human aspect, as we are even all different, even if you are not a doctor. But I think it's different from if a doctor is being callous, careless, uncaring, like more obvious bad behavior or bad professionalism. That's different. Bad personality. But I think for me, the patients I think I've felt bad about all patients going through like difficult circumstances or have poor prognosis. I've always felt bad. But I've felt bad to different degrees because sometimes you don't even have time to feel bad. You are going on to the next patient. So you don't even have time to process that. You have to go into the mental framework of, this is a different patient. We are going to discharge them this afternoon. And you're also happy for that family.
Right.
Then you go on to the next patient and you really don't know what you are doing. So there's a lot of this emotional scatter.
I like how you put it there. Right. It's just too much bipolar.
So there's a family that you are so happy that you thought this patient was going to die. They are jumping up and down. And you are happy. Then you go to the next one and just before you enter the room, you say a little prayer and hopefully you can make them feel a little bit better that they say something that would improve, and maybe that patient might. So it's not just one patient. It's just all over the place. So it's a day by day. I don't even know how we do it sometimes. It's just like a day by day.
And going off what you said, I just remembered, this last couple of weeks that I've, worked, I know how many patients have passed, and, me having to talk to their family that it was okay to, make them rest comfortably and to, make them comfortable, pretty much let them go, off the ventilator and stuff like that. I could feel and empathize with them, and they could see that you care, So I guess it just comes down to your bedside manner and the patient appreciating that you did all that you could for them. And also, just what Ibukun had said, you have to not be too emotional, because if you get into that phase, you might not be able to clearly make decisions to take care of that patient. Like the patient I lost recently, we're in the room, we kept calm, we were doing what we needed to do. Family was outside. Now imagine we're frantic. We're like, oh my God, my patient, he's dying. Oh no. Would you want that kind of doctor taking care of your loved one?
If you're not careful, you become a liability.
Yeah, exactly.
The patients that have affected me the most are patients where, at the time of admission, you can still see the vigor and health in them. And they have these long stays, and you see them gradually deteriorate. And I mean, a good number of them still end up recovering, and everything is good. But there are some, but there are some that. So it's like you see. I think I've actually had to go into the restroom to cry about 2 or 3 times. And not because I didn't feel bad for other patients, but sometimes it's just, and sometimes it's not just that patient. Maybe it's just piling up from other patients. Then that day is an overflow.
Wait, do you ever release your steam? You seem so even. I'm really worried about people like you. Right now that the way's gonna shoot up 5 places. How are you so calm about things?
I think it's the way.
Anyway, you have your wife that's like this.
I think it's the way I was made.
I'm your training.
God created me that way to be
me, then
evenly keen. Yeah, I think that's my. I'm just lucky. I think
we have a couple of questions.
But I do feel bad though. Like I told you about it. I
don't doubt you.
My colleague at work. I told like 3 nurses. Like that was my way of dealing with it.
Usually I won't let you touch when you come back from work. You have to go wash your hands. I gave you a hug because I could.
You could tell.
You needed it.
I didn't need to cry.
That was for me was your way of crying without expressing tears, because I know you don't cry easily, which is also another thing we can talk about all the time. A couple of questions before we round off some of them. Quickly, you guys have talked about some of the traits that are needed to be like a good doctor, like maintain that professional distance. Now, as far as your field is a specific field, what would you say are some of the traits you would need to be able to thrive as a hospitalist or a primary care physician?
To thrive?
Yeah, to do your job very well.
Okay. Number 1, have a good personality. Work well with staff, with nurses. Nurses can make or mar you. I've learned from experience. And even that was something that we learned, in Nigeria when we were training. Yeah, the nurses can make or mar you.
Shout out to the nurses. You guys rule the world.
You guys,
hospitals.
You guys do all the work.
Yeah.
And I appreciate you guys. Yeah. But anyway, be nice to your colleagues, both medical and non-medical staff. Have a great bedside manner. Come to the level of the patient. I just learned this recently. Weren't trained like this, but I learned on the job.
It's changed a lot,
like
because now they are wearing masks. Patients can't really read your lips, so to be able to have them see you, like almost like closer to them, you're more than compensating because of the use of masks.
Yeah, I'm having to like squat down, or squat to the level of the patient, so it's not like you're towering over them, things like that. Yeah, and always like asking them if you have any questions, concerns, like over and over again. It's just like PR. Customer satisfaction. We are graded by that too.
Yeah, but it's also different though, because this is in medicine. There's already that hierarchy between the patient and the doctor, right? There's always that distance. Mm-hmm. And how do you not erode it, but at least make the patient feel like, hey, I'm here to help you get where you need to be.
Yeah, and lastly, I'll just say, it's a stressful job. Lots of patients, lots of hours. I try to do something. Like once I'm off, I just try to decompress by playing tennis or whatever.
Tennis on Tuesdays, massage once a month, and then sometimes, his wife will hug him.
Yeah.
Yeah. All right. Ibukun, how about you?
I think mine is going to be a bit colored by what phase of my career I'm currently at, because I'm currently still training. So I would say the 2 things would be, first, at least for an ICU training, is perseverance. And there's something I tell myself during the week at different points in time is success is the ability to move from failure to failure without loss of enthusiasm. Ooh. And I think that's from Winston Churchill.
That, guys.
That's from Winston Churchill. So, because it's quite a difficult field. There are times you feel like you don't know what you're doing. There are times you feel better. Patients are pretty sick. You keep going day after day, hour after hour. So, just to keep that enthusiasm. To try and learn from your mistakes, but to go at it again. So that's for the technical aspects, and just being, like Tyrell said, being human, not just to nurses, to everyone, patients, parents, nurses, medical students, residents, your co-fellows. Just be someone people are happy to have around. I think that's where I'll put it. Just be, try and be your best self. Put your best foot forward.
Yeah. I think another thing I would like to talk about as someone married to someone that is a medical doctor is, so that you don't feel like you're enjoying your spouse as best as you can. So holidays are not always guaranteed. You have to like schedule almost your life and emotions around their monthly schedule, and that can be quite difficult. That has also created some tension in our marriage. The money is good, but then you know that if you need to do something, you have to go and check that master calendar that he's always sending. And luckily for me, well, not luckily, but I'm glad I have access to his schedule now. That I can like see, oh, okay, this day is off. He's off on this day. I guess. What are some of the? How do you guys feel about? What do you think about what I just said about? Do you sometimes feel like you're missing out on life with your family because of your work? I know for you, it's almost applicable because you're almost get married soon. So, but I'm curious to know what goes on through your mind. Do you feel somehow like you're not always there with your family because of your work?
Yeah, absolutely. I do feel that way. Like sometimes I wish that I could, get all the holidays like, primary care doctors in their offices get, 4th of July, Easter, Christmas, Thanksgiving, have all those holidays off and just spend it with your family. Of course, I feel that way. But, for hospitalists, I think they try to make things even by, you work maybe Thanksgiving and then you're off Christmas, so at least you're not missing out on both, things like that. So, yeah, I feel like sometimes I wish I could get it all, but you can't get it all. You have to compromise somewhat.
How about you?
Definitely. It's one of the reasons I, usually wonder if it was the right choice to come into medicine. Just on the low days, especially when you're just working back to back from working all weekend into a holiday. Then working all week at the same time.
And you do night calls, right? Sometimes.
Yeah, definitely. I still do nights. And that's going to be the same for the foreseeable future. I think the way, and because I'm probably not yet married, the friction isn't as bad because I stay alone currently. Yeah, it's something that I'll probably have to learn how to manage going forward once I have a family and I have children. Having to explain why I'll be absent for so and so. Probably your children will even have milestones at school that you might have to miss and all of that. So it's something definitely to think about. But at the same time, it's also sometimes on like a Christmas day, for instance, now you're in the hospital and you're taking care of a patient. Sometimes I think it's also a privilege to be there for these patients on these days. It's always a privilege, at least you are healthy, although you have to come into work, but rather be doing that than to be on the bed somewhere.
Yeah.
So it's still, maybe that's like the silver lining, or that's probably the silver lining way of looking at it. But I think it's a big privilege to be there for those people. And sometimes not everyone has family by the bedside. So sometimes we get to celebrate with them. I'd rather be with my family, but since I can't be with my family, we get to celebrate with them. So it's not all bad. Just a different way of thinking about it. Maybe it makes me feel a bit better.
Yeah. I think for me, being married to someone that I think understanding. Yeah, sometimes it's sad because Christmas they come late when they've almost had the dinner. They come back from work. They almost like they're missing out on so many things, but this is a life they've been called to live, and it has its privileges, I'm not gonna lie, but it's sometimes difficult. Sometimes you feel very lonely, and so just I think understanding, and sometimes like when he has to take like extra shifts, he lets me know like, hey babe, can you check this date before I say yes to this other opportunity. So I think just having that united front as a couple to know what you can take and what you cannot take, but the job is difficult. It's really, really difficult. Finally, before we go, I think it would be bad of us if we didn't even talk about this in very few words, is your path towards residency. And I say that because we know some of our friends are still trying to get into residency, maybe finally get that match. Match was last month, which is also March, but they call it Match Day. You match into a program. And I know you got into residency finally after on the third attempt, right? Did you have to wait a while?
You was like you got them the first time, right?
Yeah, I got it the first time.
You got the pre-match.
So what are some of the you got a pre-match? Few words, what are some of the tips you might give those that are trying to make it to finally to match? Even though you didn't really hustle like that, but what was your game plan?
Yeah, so I mean, not be the best person to give advice, but my mental model was and this is a model I've learned even past residency to apply for fellowship and everything. So when I got my step 1 score and I evaluated it, it was an okay score, probably average, maybe above average a bit. Then I evaluated it and I was quite very good in some areas. But because I was weak in other areas, it didn't matter. Do you get? You can be the best person in biochemistry. If you suck at anatomy, your score is still going to be dragged down. So when I was preparing for my step 2, my technique or strategy was not to keep studying the strong areas, but to try and strengthen the weak areas. And I think and my step 2 score was much, much, much better. And I think that has just been my strategy for life going forward, in the sense that applying for residency, you want to be, if you've not taken your exams, you want to make sure your scores are as high as they can be. If you already have your scores, then you're past that. You want to make sure you get very good letters of recommendation. You want to make sure your personal statement is on point. You want to make sure the picture you put up in your profile is on point. You want to make sure you network aggressively. Like we are, for most of us internationals, our names, we are not going to be the top picks in any way. So you want to make sure you network aggressively. And once you get your interviews, you want to make sure you prepare for these interviews like this is the job of your life. You get? So I think I've just taken that. You need to be strong. You need to be as strong as possible everywhere.
You're only as strong as your weakest area.
Yeah. Sometimes you're only as strong as your weakest area, and I think that has served me well going forward. And it's not like I'm strong everywhere, but at least for the job I'm currently doing, I already know I have like weak spots, and I already start thinking of strategies to improve those areas, because it's just like a strategy I keep using. And I think that's what's worked. I may be wrong, but I think that's what worked for me during residency. I called everyone. Not everybody was nice to me, but I kept calling. I think you are witness. I got numbers from Taiwo, called people, worked on my personal statement. I worked on my letter of recommendation. I got the scores I could, considering the circumstances. And when it was time to interview, I prepared for interview like it was a major exam. And I liked the way I sounded during my interviews, and I believe like I was a good candidate during the interviews. And I was quite confident. It's never real until the results come out. But I think I was fairly confident that I would have matched. But once I got the pre-match and I compared the programs and they weren't that different, I just didn't I'm out. So.
And I think that strategy about improving on yourself, I think it's something we can actually take, in improving our life processes. We do have that insight to see where we're weaker, but I think a lot of us just turn it off and then we focus on our strength and we keep, playing that to power. But I believe that you're only as strong as your weakest spots. So improvement, guys, and it's very continuous. It's the same way you can apply it to other areas of your life, not just, your practice or your process.
Yeah, I 100% agree with everything IDK has said. If you've not taken your boards, shoot to score the highest possible score you can get. Networking is key. Like, as a foreign trained doctor, sometimes you might not even get your application reviewed, especially if you're like an old graduate. So yeah, networking, getting them to even review your credentials and stuff like that. And then what else? The interview. Yes, you can never overstress that. I remember I interviewed the first time. I mean, I got interviewed all the 3 times I applied to residency, but after the second try, I had 7 interviews that time and I didn't match. I was so disappointed. And then I spoke with someone. I remember then I probably should reach out to her again. It's been
Taiwo, right?
Taiwo, yeah. Yes, she's my namesake. God bless
you, Taiwo.
Yeah, Taiwo.
I remember that call was on Sunday.
She was based out in Houston. She was like, she read through my CV and she was like, "What? Why have you not matched? Like, your CV is awesome.
Tell me
like, what are you doing? Like, what are you not doing right?
Yeah.
like that totally opened my brain. I'm like, okay, unlocked different channels. I'm like, oh my God, so I'm really this good. Someone can see, so I really look good to someone.
Good.
You know?
The best.
Yeah, so I had to like, okay, I became my strongest critic. Oh my God, I still carry that till today. Like, I'm my strongest critic. I don't compare myself to other people. You know, I try to just like pretty much it's consistent with what Ibukun has said, you know, locating your weak areas and working on those. So anyway, I worked on that. When I interviewed the third time, I knew I was going to match. I was cautiously optimistic. Of course, you can never be so sure.
Yeah, I remember that drive. I went to him, and I remember that drive. I saw something had changed in him. I looked at him and I was like, I'm proud of you. Whether you match or not, I'm super proud of you. Because you could tell that this was somebody that, you know, something came alive in him. Like he was just, you were a different beast playing that game.
Yeah, and like the other program I was going to match in pediatrics in New York, they sent me an email after I matched.
Why didn't you?
They're like, you know, why didn't you? Can you tell us why you did not want to come here? Something like that. I was like,
I think you got a pre-match. You actually got it wasn't like a pre, almost like they sent you an email beforehand.
Right.
Which was unusual because he's never gotten that kind of email. Almost saying that we're looking forward to having you.
Right.
You know.
Right. So that was a good experience. I realized that, you know, never look down on yourself. You know, build back that image, even though you've been cast down. You know, do not give up. Yeah. Don't give up. Anyway,
I think a lot of mistake that I've observed, and you guys can call me out on it, is as foreign trained grads, you need to be very aggressive about your networking because you didn't finish school from here. You don't have that social network. You need to buy into it. Go for conferences, have people like open doors for you. Because once you enter residency, that's it. You're almost, you know, you might not get to that level as far as someone that went here, but at least you're not going to be doing, you know, bad. So be very aggressive, no matter what your personality is. I mean, Tao is not super outgoing, but he had this tenacious ability to disturb people and block people until he got what he wanted. I remember that A4 paper that you stuck by the door.
Yeah, I wrote down
bedroom.
a list of like 30-something programs where I had contacts. I was always following up with everybody, writing, checking, applied, and yeah.
And people said, don't worry, call us clinical. See, and at the end of the day, let's not forget the place of, you know, prayers and of course, you know, God. At the end of the day, I think it's still boils down to favor. I don't know if you had any.
No, I think that covers most of it.
Yeah. And you know, it felt like when we were in that process, it felt like many years ago, and it also felt like it was never going to end. Like the whole disappointment. One time in March, you look at the results, but unfortunately, sorry, you didn't match. And then one time it happened. And those days, they don't even seem like, you know, even though they were really difficult times. So just want to encourage those that are in that process. Don't give up. Keep your networking game strong. Reach out to people. Have people read through your CV, your personal statements. Practice your mock interview skills. And learn to speak up for yourself. One of the things they noticed about Ty was that when they had like those group presentations, even though he knew the answer, he would let the women go first and have them answer the question. It wasn't being aggressive, you know. So anyways,
at the Harlem program.
Yeah.
Oh yeah, I actually spoke up that day and everybody just looked back to like, who is that person?
Yeah, he knew the answer, but you know, modest guy now, like and you know, group interviews, right? Just looking at the ones that talk first. Me, I don't have a problem with that area. My own problem is just keeping quiet when I know the answer. Because I always want to talk. Anyways, I think the next time we're going to talk about men and relationships. We have to cut it short now because, you know, this has been like 40-something minutes long. But we'll talk about just relationships, talk about some scenarios, what it's been like being single, almost married, and relationship issues and all that kind of stuff. This was fun talking to you guys, surrounded by talented people.
You're very privileged. You're welcome.
Ibukun, any final words?
Just thank you for having me. Yeah, it's been fun.
The first time in Oklahoma, right?
Yep.
Yeah.
Very nice.
He likes it. So for all of you in Oklahoma, thinking it's one boondocks. It's it's very difficult.
This is the place to be, guys. Come here.
Yeah, it's so beautiful. It's okay, Oklahoma. Alright guys, well, this has been the show. Don't forget to subscribe, share, and the next time we're going to be talking about, you know, just relationships and their perspective as men. Why some of my friends that are single, like, why are good men hard to find, and all that kind of, you know, fancy stuff. So check out this concluding episode. And I'm your host, Sibyl. T-dot out.
Peace out.
All right, that was fun. Thank you for listening to this episode of the More Sibyl podcast. Well, guess what? There's plenty more where that came from. So visit our website at www.mosibyl.com. That is www.moresibyl.com, where you can find hours of other binge-worthy episodes just like this one. And while you're at it, please don't forget to subscribe and leave us a rating on Apple Podcasts or Podbean, as it encourages other awesome people like you to listen to the podcast as well. We are now officially on Podbean. It has an app. You can catch up on missed episodes and also get a notification when we have new episodes. Do you have a question for our guest, feedback on the episode, or a suggestion for a future guest? Then please get in touch with us by sending us an email at talktomo@moresibyl.com or connect with us via Instagram at the More Sibyl Podcast. Cannot wait to hear from you, and thank you so much for always listening.